So, Rob, thank you so much for really, as usual, a very elegant presentation, and it's so good to chat.
Absolutely.
In these crazy, crazy times. So I have to represent the whole audience now and ask questions from all sorts of places.
Sure.
But I guess the first one I would ask is, do you think we've actually now moved on forever to hypofractionated radiation for prostate cancer, and never again will we do 7 or 8 weeks of treatment?
So the answer is no, and I think you know, and the reason is because you said never, and never is a big word, isn't it? And you know, there will be those patients, of course, who we feel may have an increased risk, I think, in the future for example, bowel toxicity. We may find that actually through some of the comorbidity data that we talked about before. And those need a more gentle regimen in order to handle their normal toxicity, and the 2 gray fraction, or even potentially less, but maybe twice a day for some patients might suffice. And yet in other patients, yeah, I think we are going to move on towards that. I would say certainly in Manchester, and also, as you know, in a previous life, I was Canadian. In Toronto, 60 gray and 20 fractions is a standard. And it was a standard based on randomized clinical trials in Canada. And it was a standard when I came to Manchester, where, you know, really led probably the UK and the world in starting hypofractionation regimes sometime in the past. But we've moved on, haven't we, to 5 or 7 fractions. And the data, at least at the present time, tend to support that we are not really seeing any surprisingly undue toxicity based on patient-reported outcomes, which is, you know, really the standard. And also that we are not seeing, at least in the piece of data that we look at, you know, 4 or 5 years out in some of the extreme hyperfractionation regimes, that biochemical failures are increased. And I think, of course, we'll also have to be thinking a little bit more in terms of the bespoke use of radiotherapy. I mean, clearly for patients who are low intermediate risk, where we believe that a local treatment is required, hypofractionation or ultrafractionation is quite reasonable. As we start to get into larger volume tumors, locally advanced cancers, we may even think about you know, potential biomarkers in the future that suggest that lymph nodes absolutely need to be irradiated. It may be difficult getting in 5 gray fractions into the lymph nodes with that small bowel in order to maintain you know, a very, very low incidence of gut toxicity. So in those particular regimens, then you probably are going to be seeing the 4 weeks of radiotherapy. But I don't know that we'll go back to the 39 fractions. And I do think in around 5 years' time or so, many institutions, as I said, except for exceptional cases, will be at the 4-week mark, and many patients will be receiving 5 to 7 fractions appropriately. So what we don't have right now is a biomarker to say who should receive hypofractionation. It's one of the controversial pieces. In other words, is there a benefit to using decreased numbers of treatment in terms of the alpha beta ratio, and looking at the relative radio response of tumor tissues versus normal tissues? And we don't have that signature at the present time. But what we do have is an increasing ability to deposit dose where we want to deposit, to track movement during radiotherapy. And I think that if we want to throw something kind of interesting in, the question will be, you know, the era of flash radiotherapy. We hear a lot about this these days, where literally the treatment is given in less than a second. It's at least a decade off, you know, in terms of its implementation. But it suggests that dose can be given, which at least in the preclinical models and just human trials are starting, where you maintain the tumoricidal dose, but actually you really decrease the toxicity to tissues in the pelvis, particularly small bowel. So that's kind of an up and coming piece. And that, of course, is the true ultrafractionation, in the sense that a treatment is given in less than a second. And in that case, you might only be giving a few treatments. So time will tell, but research is ongoing.
Fantastic. I'm now going to move across to some of the real world outcomes, and possibly go through, I'm fascinated by some of the things that you got into the home. How does a wearable cytokine release syndrome or cytokine storm monitor work?
Yeah, so it's really interesting, isn't it? And so the perfect alignment of a biosensor against skin, trying to pick up again specific enzymatic reactions is not perfectly worked out just yet. But that is absolutely something that we want to do, and you can almost think of it as a lab on a chip, but flipped over against the skin surface and looking for patterns within sweat. That's down the road. I think the simplest things, of course, is that along with the cytokine storm or sepsis or changes in respiratory patterns, heart rate, but actually mobility. And so activity becomes a very interesting surrogate for infection, and because you're not getting out of bed and you're not moving around and you're feeling unwell. And so the trick here, of course, is to start to see how well that reads out, and that is an important addition to anything that the patient themselves is picking up with respect to their own symptoms, and then calling into that hotline. So it is a way for perhaps patients who aren't as self-aware to be picking up these early signs. And I think actually it's not kind of a big brother or big sister approach, but it also allows again a kind of an at distance monitoring, particularly for patients who might be socially at risk for other reasons and are adverse to coming into hospital. Sometimes, as you know, there's financial toxicity associated with our treatments. So for these sorts of individuals, these devices we hope will be game changing for them. But I think it's absolutely fair to say that we're really in a kind of a phase one surrogacy. It doesn't really work for whom, and where will this be placed in the next 5 years or so. But it forces people, and it certainly forced us, to be working with our advanced materials departments, within the university, and really reaching out for some of the innovative pieces around that. I think that, having a digital experimental cancer medicine team, along with within a phase one setting that already has a high activity of novel phase one trials, is a very exciting venture for us, and we certainly hope that people will see that from the outside, people who are in the physical sciences or engineering sciences, to come and actually see how we can collaborate best together. So we're getting that message out quite aggressively. And the fact that, again, you have the ECMC centers with the United Kingdom and some even outside the United Kingdom collaborating suggests that we'll probably accrue data fairly quickly in this regard.
I mean, I'm particularly interested, given some of the data presented at ESMO, around, for instance, the bispecific, the AMG 160 bispecific antibody. I am somewhat biased because I'm one of the phase one sites. Right. But that's exactly the side, to be able to track cytokine release syndrome gets people out of hospital faster after they have it. Are you actually already being able to send the information in real time back to the hospital and having people check it? Have you reached that stage?
So the pilot studies with Fiona Thistlethwaite and John Radford have piloted that, and the answer is yes. But the actual formal trials are just getting started, to be honest. And again, having a wave 2 of COVID allows us to do that. I think the other piece you mentioned is quite important, right? Which, this is not a magical device that will be able to detect everything off of skin. I think what we're talking about is that if, for example, your wearable says, take blood test now, and you have an ability to do a pinprick at home, and then you can send that information, again, electronically to the Christie, then that's also another maneuver. It's more invasive, but it's within the home. And so that type of data we do have ongoing within one of the digital team trials, particularly looking at renal activity and taking blood tests for patients, looking at kidney function on different trials, and then switching patients to other trials based on that result. So that, of course, does require the callback and further interaction in a human interface. But I think that, at least with respect to entering clinical trial data, symptoms, et cetera, there really isn't any difference from doing that on the iPhone for those that can. And for those that can't, elderly, et cetera, or don't have access to it, then it'll still be on the phone, or because we did a lot of telemedicine, didn't we, during this period of time? Yeah.
That was going to be my next question. Telemedicine, even in Australia, is still very alive and well, just to keep the waiting rooms
Yeah.
from being too full. Where is that in? How has that worked in the UK, and is it still ongoing?
Yeah, it's still ongoing. I think some trusts were set up to do telemedicine in a big way better than others because they'd already started. I think actually, interesting enough, some of the kind of acute care trusts that were already using telemedicine in a large way. The Christie were a little bit behind in that area, but yet that was one of the pieces I was mentioning about, having to see IT not as an obstructive group of people within the hospital that never get done what you want to get done. It was really flipped on its end, and resources were placed into it so that actually telemedicine and home phones were, became increasingly a regular basis. And also, what's important is to do multidisciplinary care and actually have a three-way, right, or a four-way with a patient. And that is being explored and was successful in certain specialties. So I think that absolutely is here to stay. And I think that, again, it'll be interesting, won't it, that if you have a patient that can't come into hospital and you want a multidisciplinary opinion, will be a half hour at the end of every clinic in which, again, people get onto Zooms with the patient and actually have a multidisciplinary consultation that right there and then. And that, in some ways, you would say takes a lot of time to organize, et cetera. But when you start to think about the organization of separate visits for that individual, in potentially an ambulance to bring them in, et cetera, went from a single payer, healthcare system resource where the bucket is limited. Actually, it might be saving money.
I mean, within a month of starting it, actually had waiting rooms for multidisciplinary care on video.
Yeah.
And that was from technology that already existed, just people weren't using it that much. So I've been blown away by what you can do. In fact, even blown away from what you can do on an iPhone, which I
yes, absolutely, yeah.
There's been a lot of talk about the delay in diagnosis. And that we will see a lot of excess deaths from cancer, from many other diseases, but from cancer at the end of this. Is there any data yet from your centre and from the UK as to what the magnitude of that is likely to be?
Yeah, so the estimations are in the order of 3,000 to 5,000 extra deaths, based on the data that are coming through. I have to say that they're actively debated, the numbers and the models that are being utilized, and again, for something, the main issue for us is for any disease that required scoping, endoscopy in any way for our patients, because that was completely curtailed during the summer. So that's the worry, and we certainly are hearing the anecdotal reports, of patients coming in when you're at the scale of the Christie, and when you hear all of these busy clinicians saying, "Wow, we're really seeing more advanced disease now," just with that, 4-month period, really, then you have to start to think that we're going to start to see some true statistic about what that's looking like, probably. By end of Q2 2021, I think we'll really have a sense of what that delay was like. So it's very impressive. It of course hit all of our lay press and in all of our countries, and major concerns from patient advocates and charities, and rightfully so. I think that is the other reason, of course, from a Christie standpoint, that looking at all the data, there's absolutely no shielding. It's standard of care, and everybody is getting treated, and they're getting treated judiciously and rapidly. That, of course, again, puts lots of pressure on the healthcare system. One of the queries then comes down to clinical trials, and are we able to have all clinical trials up and running as we see this kind of wave of patients coming forward? And at the present time, site groups are asked to prioritize trials that they feel are most important for the, for patient impact and for the impact of the Christie nationally and internationally in that space. So far, we have not declined or we have not stopped any trials or restarted on May 11th, but that may have to occur. So I think that's at least one thing that is important, which is that with the increasing numbers, et cetera, workforces will be sorted and people, but I think that there's a recognition now that the academic and research programs must continue at the time. Because it's one thing to say that we've had a delay and now we have all these excess cases coming in. I think it would be worse, and we heard this, didn't we, from patients as well, to say, oh, and by the way, we're not running any clinical trials. And, and in fact, we need to be perhaps changing rapidly some of our clinical trials to potentially take into account some of the more aggressive cancers that we're seeing and actually make sure that we have enough trials to really test out novel treatments in that group of patients who otherwise will have an adverse prognosis.
Yep. We also might stop doing a whole pile of trial things that probably never needed to be done in the first place.
Well, thanks, Lisa, and it's always such a pleasure. I'm sorry that I can't be there in person because ANZUP is one of those meetings. First of all, you and your colleagues are great people. You're great physicians. You're great scientists, and I love interacting with all of you. I think that as we go forward, these types of meetings and these types of sessions, sharing our experiences are really important to get it right for those things in which our healthcare systems are similar. And then also, these sessions are quite interesting, aren't they? Because you hear some pearls from other healthcare, and so we can synthesize and synergize and bring that into our own healthcare system. So thank you for the opportunity today to share a little bit about the UK experience.
Well, thank you very much. That's been fascinating as always. I look forward to being able to see you in person, hopefully in the next year when we all have a vaccination passport.
Yep.
Preferably not an immunity passport because none of us want to get it. And all the best and Merry Christmas.
Absolutely. And to you too, and to all your colleagues. Bye, Lisa, for now. Cheers.
Bye.